All right, good morning, everyone. Thank you for joining us for the breakout session with a focus on rural health. We have some excellent speakers this morning, and each speaker will have about 20 minutes, and then we're going to hold all questions until all three speakers have gone. So to start us off, we're going to start with Dr. Renzi-Hammond and Dr. Beer. So take it away.
Hi, everyone. I'm Jenay Beer.
And I'm Lisa Renzi-Hammond.
And we will be talking about aging. We look forward to hearing about mental health and management of chronic diseases later in this session. So to kick off our presentation, I would like everyone to take a moment and picture yourself at the age of 80. What are you doing? Are you enjoying your retirement? Are you traveling? Are you golfing? Spending time with your grandkids? Everyone has a vision of what healthy aging looks like and how we each individually want to achieve it. However, with age also comes uncertainty. When asked about fears related to aging, most people do not cite wrinkles or gray hair. Instead, most people cite the fear of losing their memory. Now, standard measures have been created to assess a fear of flying, a fear of spiders, fear of enclosed spaces. What I'm showing you here are items from a validated survey measuring fear of dementia. These survey items are profound and emotional. In fact, some of these items might emotionally impact some of you in this audience. And you are not alone. A recent national survey of adults aged 50 to 64 years have found that nearly half of all respondents feared being diagnosed with dementia. This well-founded fear is so common among middle-aged and older adults that the term anticipatory dementia has been coined, and assessments such as this one have been developed to measure it. So to zoom in on this problem in Georgia, we have a lot of work that needs to be done as it relates to healthy aging. We are ranked 50th in healthcare for older persons. A whopping $355 billion has been spent on Alzheimer's disease and related dementias, healthcare in Georgia alone. And this is only going to get worse. Since 2018, in the past 3 years, there's been a 37.5% increase in ADRD incidence, and that's only going to continue to go up. In fact, Medicaid costs are expected to increase by 40.4% by 2025. Now, for those of you who have served as caregivers for persons with dementia, you know how taxing that can be. And Georgians have provided 600,000 hours of unpaid care for persons with ADRD, and that's valued at $7.5 billion. Now, let's not forget about the actual health of our caregivers. Georgia's caregivers have spent an additional $304 million for stress-related medical expenses. Now, thinking about these issues, Georgia in particular has many barriers to face because 70% of the counties in Georgia are rural. And there are very unique knowledge, cultural, infrastructure, and economic barriers that minimize access to ADRD diagnosis and interventions for these rural populations. So let's start with knowledge barriers. Many of you have heard the term old-timers disease. And this implies that when you get old, you must get dementia. And this misconception is a problem because older adults don't understand what is normal in terms of memory changes with age and what is not. In fact, 80% of people who experience cognitive deficits in Georgia have not discussed that loss with a healthcare provider. Low health literacy and mistrust in science are also prevalent in rural communities. And should these knowledge and cultural barriers to diagnosis be overcome, there's still an infrastructure issue. Approximately 20% of Americans live in rural communities, but only 8% of specialty physicians actually practice in rural communities. And this creates a physical barrier to diagnosis. To complicate matters, rural healthcare systems often lack neuroimaging equipment, cognitive testing tools, and advanced laboratory facilities needed to diagnose and treat ADRD. So this is creating infrastructure and economic barriers to diagnosis, only adding to the extensive medical expenses discussed on the previous slide. So in summary, knowledge, cultural, and infrastructure and economic barriers partly explain why rural communities with different lifestyles, healthcare access, and resources tend to have issues accessing education, diagnosis, and post-diagnosis support. To address these unique challenges, we have to come up with unique solutions.
So you've heard a lot about barriers now this morning. You understand sort of the magnitude of the problem that we're facing economically. I think if I were to see you all in person, if we were in a room together, and Jenay and I were to say, raise your hands if you have been impacted by dementia, if someone in your family was actually diagnosed, if you've seen it firsthand, our hands would go up. And I suspect a lot of people on this call would be feeling the same way. We've heard about barriers. I think lots of us have lived those barriers. So we are delighted to tell you about our solution to those barriers. So we are a solution-focused group. This is sort of what we're after. So I'm going to spend the next few minutes introducing a few of the 13 separate academic units at the University of Georgia, as well as our state level partners who have joined the Cognitive Aging Research and Education Initiative, or the CARE Initiative. So what is our mission? Why are we doing this? We have lived through it with our family members. We don't want to see anyone else have to live through it. And if they do, we want to see this whole problem differently. So together we've joined forces to forge a new pathway to living with dementias. And the underline on the screen is not sufficient really to get us to this concept of living with dementia. However you felt when you saw those items that Jenay showed on the screen a little bit earlier, imagine how it feels to be the person to receive that diagnosis. We hear over and over from our clients the frustration, the hopelessness, the statement that that is the worst day of their life. But life does not end with a diagnosis. People are living longer and longer lives with dementia, on average now about 10 to 12 years post-diagnosis. That is a significant chunk of life. So our team focuses on living with dementia by working in 3 basic areas. So first and foremost, we're public health, it's education. That's where everything sort of starts here. We're focused on education. We're then focused on working on infrastructure to expand access to diagnosis and post-diagnosis support. Now, these activities are tailored to each community that we work in, designed with and alongside each community. And each set of activities takes advantages of the unique strengths that are present in each community. We're going to dig into each of these activities separately momentarily, but first, we'd like to go ahead and introduce the team that makes this work possible. The University of Georgia is a resource-rich environment. We have specialized equipment, healthcare providers on staff with expertise and passion, and students and trainees at all levels of their education who are really inspired to dig in and tackle big problems like this one. Perhaps most importantly, for the purposes of this discussion, we have Jenay and stable broadband. So to get these resources that we have here at the university out to our local communities, again, we're working with lots and lots of different folks across the state and within the university, but here we're going to focus on 3 beloved institutions that have really done a lot of the heavy lifting with us. The first one is cooperative extension, which in our opinion, we should all be thinking about as a national treasure. So cooperative extension agents and educators live and work in all of Georgia's communities and have served as a trusted source of information in Georgia for more than 100 years. That's a lot of built community capital and trust. Your coax agent tests your water. Your coax agent teaches your kids how to show goats, which in my opinion might be the greatest thing ever. They provide nutrition advice, financial advice, and now they just might be the ones to help you prevent Alzheimer's disease. Next, I'll highlight the work of UGA's Archway Partnership, which really focuses on economic development. You saw the magnitude of the economic problem that Alzheimer's disease represents to rural Georgia and to the rest of the state. Our Archway professionals live and work in their communities, and they form interest working groups aimed at tackling a specific problem of specific interest to a specific community, like healthcare infrastructure. Archway professionals gathered key stakeholders from the city mayor to the head of Parks and Rec to the chief financial officer of the local hospital and join all together to solve problems, like in our case, lack of access to dementia diagnosis and post-diagnosis support. And finally, we'd like to turn a spotlight onto our state partners in the Department of Public Health, who also believe that rural Georgia provides an extraordinary opportunity to collaboratively improve the public's health. We've been working with them for the last year and into the foreseeable future on the CDC-funded Be Seen project, which aims to tackle Alzheimer's disease and related dementias statewide. So now let's dig into each area of the model. So when it comes to education, we have lots of different stakeholders who we're targeting for education. And perhaps first and most obviously, we educate the public at large. Our public education campaigns focus on brain health, dementia prevention, and understanding when cognitive loss is a normal part of aging and when it signals something a little bit more sinister. So we've taken these campaigns nationally thanks to our partners at the Alzheimer's Association and even internationally, courtesy of the TED stage. Now, we also educate healthcare providers. You can see this is an international initiative that we had to go out and talk to healthcare providers all over the world. This is a group of doctors in Singapore in this particular image. So the most common things that we hear from doctors, and interestingly, this is not just statewide, this is worldwide. The most common things we hear are, yes, I see that there's a problem. I could provide a diagnosis, but what's the point? There's nothing for it. It's a terminal disease. So why bother? Just let them live the way they're living and don't worry about it. You know, whatever happens will happen. We hear that a lot, a shocking amount in rural Georgia. So we are working, gathering information, as you're going to see in our progress report in just a moment, from interest working groups in our rural communities, loaded with healthcare providers who are able to tell us, here's what I think, here's what I know, change my mind. And that is our job. We are developing tailored education for healthcare providers in our rural communities, aimed at providing tools for what one can do after a diagnosis. Now, we also educate the workforce of tomorrow. Our students will be the future workforce for the state of Georgia. We are creating an interdisciplinary, interprofessional workforce aimed at getting our students out of the lab and into the community to hear the perspectives of future patients and clients. Now, finally, of course, we educate communities. We develop educational campaigns iteratively with the assistance of our local cooperative extension agents who have their eyes and ears on the ground in these communities. Now, an education campaign will vary and be scalable from community to community. In some communities, it might be, we don't really want to hear this right now, but you can leave us a pamphlet at the doctor's office. And that's a start. That's our foot in the door. In some communities, it's, can you develop a program? We have people who really want to focus on brain health, and they need a place where they can go every week to learn. And the answer is, yes, we can. Now, we know that there are other stakeholders in need of education, such as government officials at state and local levels, law enforcement and first responders, and other groups like that. We are definitely going to get there in the future, but this is where we decided to start. Now, when it comes to access to diagnosis, as you heard Jenay say, is an infrastructure-heavy process. It requires an honest conversation with your healthcare provider, and you heard Jenay say that 80% of Georgians aren't having that conversation at all. And then once you have that conversation, diagnosis is a multi-step process of elimination, basically, which requires a geriatric medical exam, laboratory testing, hours of neuropsychological assessment and diagnostic interviewing, neuroimaging, and in some cases, even maybe a lumbar puncture to look for proteins. That's a lot. Given the barriers that we described earlier, this is simply out of reach for so many Georgians. In the CARE initiative, cooperative extension offices and other key community sites with robust broadband access become places where community members who cannot access these services can reach a specialist at the Care Center hub here in Hudson Hall on the Health Sciences campus where Jenay and I are currently, who can provide some of these services from a distance, like neuropsychological assessment and diagnostic interviewing. Now, finally, we have to focus on support. We're going to give you a brief progress update before we give you some lessons learned. But again, that major barrier that doctors tend to report is, why bother diagnosing if there's nothing I can do about it anyway? That sentiment is the focus of our support initiatives. We and our student trainees have worked and are working to create and continuously update 159 unique post-diagnosis support guides that provide information to persons living with dementia and their care partners on everything from how to access compassionate allowances to Social Security and Medicare to how to have library books delivered to the house. We also partner with local businesses who can help us deliver support programming using technology.
So much of our time has been spent laying the extensive groundwork for collaborating with rural communities. So to start, we chose 4 pilot communities based on the guidance of our partners, the UGA Archway Partnership and Cooperative Extension. And these communities are Grady, McDuffie, Hart, and Washington counties. These communities are geographically spread throughout Georgia, and each community represents a unique set of strengths and opportunities, as well as readiness to tackle this problem. So let me tell you a little bit more about our ongoing work in these counties. So as Lisa mentioned, the first is forming and engaging interest working groups. So through Archway, we've identified stakeholders in each county, and we've engaged in multiple listening sessions, ride-alongs, and focus groups with those stakeholders to really understand the problem in each community and how they might want to address it in collaboration with us. We're iteratively designing, delivering, and evaluating community education. As Lisa said, public health, community, or education in the community is key. We're also conducting healthcare needs assessments, so meeting with healthcare stakeholders in each community to understand where they stand in terms of infrastructure and how UGA resources might help aid them in addressing this problem. This also includes telehealth readiness. I'm sure many of you have heard telehealth is the answer for rural healthcare, and it drives me nuts to hear that because it's a challenge. While there's many opportunities for telehealth, it has to be implemented very carefully, very thoughtfully. Broadband can be an issue in many rural areas. So thinking creatively about where the resources are in each community and where telehealth will fit into the workflow. We're also accrediting CE and CME for healthcare providers. Healthcare providers need to understand what is dementia, how to diagnose it, how to spot it, and then how to refer their patients to centers like ours to receive diagnosis and support. Lisa also mentioned tailoring support and resource guides. We are creating resource guides for all 159 counties throughout Georgia. And we're also tailoring support, so creating booklets, pamphlets, educational materials for post-diagnosis support, focusing not only on the person living with dementia, but also their caregivers. And then finally, expanding to additional counties. We've been working in depth with the 4 counties that I mentioned earlier, but our 5-year plan is to expand throughout the entire state. So prior to fully implementing an intervention, so much groundwork was required to get buy-in from these communities. And we've spent the past year working on that groundwork. And there are many lessons learned, and each relate to the unique barriers that we discussed earlier in this presentation. So let's start with lessons learned related to knowledge. So first, as Lisa conveyed, education is key. Without education, the community is not equipped to tackle this challenge. Our extensive education program involves co-ex educators delivering curriculum to our 4 counties and soon throughout the state. These curriculum materials need to be adapted to match the unique needs of each community. We have also learned that education needs to be delivered flexibly. I can't tell you how many meetings Lisa and I have attended in rural communities where we're unsure if we're expected to present a PowerPoint, engage a discussion, engage in small groups. So we have to be ready for all of the above when we arrive in that community. We've addressed many cultural barriers as well. We've learned to lean heavily on our partners who understand the community and get our vision. These partners are gatekeepers with credibility and established trust. It's also important to lean in to each community and use the resources that you have. Go Dogs means something special in rural Georgia. Finally, stakeholders come from unexpected places. For example, we've learned that the best way to find older adults in rural Georgia is actually at daycares. Grandparents are often involved in daycare drop-offs and pickups.
So in addition to lessons learned on those two fronts, we definitely are learning some lessons on the infrastructure and economic fronts too. Now, these are obviously related issues, but they are actually a little bit different. So when it comes to infrastructure, this is where creativity is really, really key. When we started this initiative, I don't think that either of us thought that we would be going into cooperative extension offices going, how's your broadband? Can we test your signal? That little nook over there, could we? That maybe that needs a computer and a little spot for us to interview humans. So it's one of those situations where goat owning Lisa loves the idea of being able to show my goat and actually, have a phone call about my medical health in the same day. And that's exactly what we're after. We are looking for solutions that fit each community, and sometimes they come in unexpected places. Sort of related to that, I think that when we start talking about things like economic barriers, there's a lot of things we could put into this box, but you'll see we only have one item in there, because to me, the biggest lesson that we have taken away when it comes to understanding the economic impact of what we're doing is that 1, there needs to be one, 2, it needs to be calculated very specifically, and 3, it looks very different to different stakeholders. So when you're engaging in rural health work and you're thinking about what your program means in one community, it might just be the case that whoever is the mayor of the town actually faced this problem firsthand and is all in with purse strings because it's personal. In other communities, you might need to go in and say, what is the big problem that you're facing? Potentially, it's actually a problem that a different public health program would address, like say diabetes, which is a risk factor for dementia. Or mental health, which is also, mental health complaints are also a risk factor for dementia, and persons living with dementia and their care partners are a lot more likely to experience negative mental health outcomes. So sometimes it means grasping onto whatever it is that the community really needs and finding ways for you to still deliver benefits and return on the investment that community has given you in time, in resources, in whatever it is. So, calculating a return on investment can be tricky business. Depending on which stakeholders you're actually speaking to. And of course, there are often more than one. So lots of lessons learned, lots of hard work. I expect that we could come back to you next year with a totally different story, and the year after that with lots more progress. This is definitely a work in progress, as good public health always is. So on that note, we will go ahead and turn over the floor. So we would like to acknowledge all of our partners in this initiative. First of all, our bedrock, the UGA College of Public Health, who has supported us through this entire process of us going to our dean and saying, hey, have you thought about dementia? Can we discuss? As well as the Department of Public Health, who has helped fund us through this bold public health initiative. And through, our Extension and Archway colleagues who have been so giving of their time, their resources, their knowledge, and have trusted us with the communities where they have forged relationships over time, and were willing to kind of bring us into the fold. And then, of course, we'd also like to thank Public Service and Outreach at the University of Georgia. The Vice President for Public Service and Outreach's office was kind enough to give us a seed grant to kick us off in some of this work. So on that note, we will hope that you have great questions. We look forward to hearing them very soon. And in the meantime, we would love to turn it over to the next presenter.
Thank you, Dr. Hammond and Dr. Beer. Next up, we've got Andrea Scarrow.
Good morning, everyone. And Shellie, can you see my screen okay?
Yep.
Okay, wonderful. Well, I just am delighted to be with you all today, and I really appreciated the presentation from Lisa and Jenay. It was very relevant. I am the District Director for Southwest District Extension in Georgia, rural Georgia, and I so appreciate the work that they shared with us. And how they've been able to partner with us in Extension. I love the fact that they think we're a national treasure. So I thank y'all for being in one of my counties, Grady County, and I've enjoyed a very lovely partnership with the College of Public Health since about 2009, when I got to know Dean Marcia Davis. And I just think that it's been a great marriage of collaboration partners between Cooperative Extension and College of Public Health now for many years. And so it's delightful to be here with you today and share a little bit about a new area that we're working in Cooperative Extension along with many partners. in the area of farmer stress and suicide prevention. And this is quite different for us in cooperative extension. We are not in any means prepared or licensed mental health workers. And so we've depended on our partners at the community level, as well as colleagues in the School of Social Work, Dr. Anna Chayette, and others who are working in this field, along with some of you there at the College of Public Health. It's been a great partnership recently with Dr. Christina Proctor and her efforts in reaching the community, trying to measure what does mental health look like, and how do we measure that in our rural communities. So I appreciate her work and the opportunity to partner with her as well. But about 2019, end of 2019, in cooperative extension, this came on our radar because at the time, Dean Sam Perdue, the College of Agricultural and Environmental Sciences, was very passionate about this topic. There was a Rural Stress Summit in Georgia, I think the first of its kind. And this came on our radar specifically after the Hurricane Michael in 2018, which affected Southwest District counties so heavily, with millions of dollars in losses for our farmers and their families. And it's very impactful when you stand with those farmers and their families on the farm and you survey the losses and you cry together and you realize this is hard, this is very difficult, and we're not even sure how we'll recover. And it was very life-changing for me as a farmer's daughter. I've been always concerned about the family farm, and my brother, who carries that on now, been in touch with the stress that he carries daily, just for so many unknown factors. And so I was personally very interested and challenged by this topic of how could we, in cooperative extension with our partners at the university and in the communities, how could we leverage resources to better help and address and just connect our farmers with mental health resources that they needed. It's a touchy subject, and so we thought long and hard about how do we bring up the topic of suicide with our farm families. And we took I think a somewhat unique approach. Our message is to them, you are the most important asset on your farm. So we want you to have the resources necessary to take care of yourself. And so we began to talk and brainstorm, and we have an ag and natural resources agent in just about every one of my 41 counties in Southwest District. And they had mostly had experiences where they were the listening ear for the farmer in hard times, whether it's economic times or weather conditions or what have you, but they did not feel comfortable really pointing them to mental health resources or mental health providers. And so the first big step was to get ourselves, our agents and ourselves in our county offices, a little more comfortable with the topic. So at our district conference that year, we had a speaker, a young man by the name of Marshall Sewell, who lost his father to suicide. His father and his family owned a large farm, strawberry farm, down in Florida. And he came and he spoke with us. And the day after, I had agents calling me saying, I've checked in with all my farmers this morning. I think they're doing okay today. It really made an impact on our agents. It really sensitized them to the need among the clientele that they were working with. So from that, we kind of launched this campaign that we called Rural Georgia Growing Stronger. Part of that was connecting with the Georgia Department of Behavioral Health and Developmental Disabilities and our regional representatives to link us to the resources and to help us curate what some of the best resources and trainings were for our agents. So we now have this website, extension.uga.edu/rural, where we have resources that the public can access. And as we developed these resources, we pulled together a pilot project here in Southwest District. and we called it Southwest Rural Stress Partnership. And our UGA partners included some of those already mentioned, the Archway Partnership, which we based our meetings out of Colquitt County, where we do have the Archway, an Archway professional. So Sarah Adams has helped us there. The College of Family and Consumer Sciences, of course, Cooperative Extension works with both the College of Ag and the College of Family and Consumer Sciences. And so our partners in the College of Family and Consumer Sciences, I'll talk about in a few more minutes. And then, of course, Ag and Environmental Sciences. I've mentioned Dr. Anna Chayette, UGA School of Social Work, and she's helped us time after time and is a part of this partnership. And the UGA Small Business Development Center as well participates on these calls, those especially who are working in rural Georgia. Our agency partners in the region are many and varied also. I mentioned the Department of Behavioral Health and Developmental Disabilities. We also connected with the South Georgia Medical Education and Research Consortium in Colquitt County, along with the Colquitt Regional Medical Center. And I'll show you in a minute exactly how they came alongside and helped us do the outreach piece through Extension. There is also the Philadelphia College of Medicine in South Georgia and licensed social workers from Family Recovery of South Georgia. So we involved, beyond these folks, we involved just other partner agencies, some of the ministers in the area, and it's grown and grown, and it's being replicated now in some other of our districts as well. So what did we do? How did we kind of soft pedal and enter into this area where, as extension agents, we all felt a little bit uncomfortable to start with? Well, we piloted at our ag production meetings an opportunity, a very brief 5-minute presentation on mental health resources after we offered blood pressure checks and just some resources on chronic disease prevention, because we do understand that chronic diseases can be a contributing factor to stress and even suicide. And so at 3 or 4 of our county ag production meetings, which happen typically in January and February each year, we encounter about 3,000 farmers every year. And during these meetings, of course, we just piloted in 3 counties. So we had probably 300 to 400 that we connected with at those sessions. They come because they want to know what planting season looks like. They want to know all of the latest and greatest tools, what the UGA scientists are recommending, whether it's herbicides or pest control or when to plant, new varieties of seeds to plant. They're getting all the latest, greatest research that's really going to impact their bottom line that year. And they're going to use those tools to help them as best possible have the best crop and the best yield. And they come to those meetings kind of in that mindset. So we knew we would just have a few minutes at the onset of the meeting to kind of present some other resources to them and just let them know, hey, we're here, we care about not just your bottom line, but we care about you too. So here's some resources for you. And if you have questions or you need more, then please let us know. You'll notice in this picture over to the left, Jennifer Dunn is our partner at the Behavioral Health and Developmental Disabilities Department, and she is a farmer's daughter too, and she was able to kind of speak their language and just say, hey, if you have any concerns or questions, just give me a call. And inevitably, after each of these meetings, 2 or 3, sometimes 4 of our farmers would call Jennifer and say, you know, this stress thing, I need more resources. I need more help. That was huge in our minds, that there was that sort of response to a 5-minute presentation on these resources. And so this was the pilot that we did in early 2020 before we were shut down for the pandemic. And we hope to continue again early in 2022. Along with this, as I said, we had blood pressure checks going on. We had nurses and doctors out available to discuss any health needs that the farmers wanted to talk about. over to the side or off in a private room in some instances. And so here you see Dr. Stanley Culpepper, one of our scientists, weed scientists, showing the way, modeling the way, and getting his blood pressure checked. We curated, as I said, many resources to go up on this public-facing website, whether it's managing stress or farm credit, staying healthy, disaster recovery, budgeting tools, and even youth farm stress, because we understand that young people carry the stress of the farm too. And it was very interesting after Hurricane Michael that our livestock shows, as Lisa mentioned, our goat shows and our swine shows and our cow shows, all of those livestock events for those youth affected by the hurricane were even more important than ever, because it gave them some sense of normality and moving forward, and that they had that peer group that they could continue to relate to. So we understand that youth experience farm stress as well, and we want to be mindful of their needs. We also make very public and very present on our website and on any materials that we hand out, all of the support lines that are available through the Department of Health. So we have that front and center on any of the resources that we're sharing. Along with this, we have been able at the College of Family Consumer Sciences, our extension specialists there have been able to apply for what we call the FR-SAN grant, Farmer and Ranchers Grant on stress, for stress. And Dr. Diane Bells and Rebecca Brightwell lead that initiative. And we are working to expand the scope of our reach throughout the state. I'll give you just an idea of what this grant entails and kind of how this is helping our statewide effort on rural stress. The grant was established nationally to develop this service provider network that will assist farmers and ranchers and other agricultural workers with stress management. It really offers a lot of awareness for improved mental health and providing greater access to rural communities. It is supported by NIFA, a branch of USDA, and awarded to 4 regional entities. And you'll see the scope of this. It's very encouraging that nationally we're addressing this through cooperative extension, through our partnerships. You see that we're in Georgia, we're located in the southern region. So there are these 4 vast regions who are working on this effort and supported by this grant. Some of the objectives you can see will sound very familiar to you: building that positive morale and support at the community level, increasing the awareness at the community level, increasing community members and professionals, their confidence in addressing farmer stress and mental health suicide, or mental health issues rather. And one of the things that we've been able to do is send some of our agents to mental health first aid training and the QPR training, which I'll talk about in a minute, so that they feel a little more prepared when a farmer brings it up to them and can connect them to the resources. So again, communicating and collecting the resources and making those available. And we hope to increase the effort by establishing a peer-to-peer, farmer-to-farmer network and help them talk about the mental health issues together. So we've come across several trainings, one of those offered by Farm Bureau, the Rural Resilience Training that we're also encouraging our agents and farmers to take advantage of. We have, through the collaboration with Dr. Anna Chayette, been able to make our website available across the nation to others through the Farm Bureau, Farm State of Mind, Health Resources page. And so there are resources there for every state, and UGA is happy to be among those who are providing connections and resources on this issue. I just want to just want to mention Dr. Cheyette's work that's really informed our efforts on this. She did a pretty extensive survey at the 2019 Georgia Farm Bureau annual conference, asking participants there their thoughts on stress. And I just wanted to share a couple of slides with you from what she discovered. And you see that from this first slide is an assessment of the stress levels in Georgia farmers. Farmers themselves recognize that they're under stress, and compared to a year ago, they think that that stress is increasing. Along with that, this slide just shows, how confident do you feel that you'd be able to help someone who was expressing high levels of stress or even thoughts of suicide. We've got a long way to go to help our communities feel prepared to speak to this issue and to offer help. And then what were some of the top stressors? And at that time, weather, finances, of course, commodity prices, operating costs, so many things that are really outside of a farmer's control contribute to this stress. So a lot more research needs to be done. We are working to ask farmers, as this slide shows, how do they like to receive this information? Is it at the production meeting face-to-face? Is it through social media? They access a lot of farm magazines. Do they attend classes where they want to hear about this? So we're trying to really hone in on what is the best way to communicate the resources to our farmers. Just in closing, just want to share with you a few of our other outreach ideas and kind of where we're going with this. As I mentioned, we're doing mental health first aid trainings for our agents, which equips them to just be a little more knowledgeable about the topic. There's also the QPR training, question, persuade, and refer, for specifically for suicide prevention. And then we're continuing to partner with our healthcare providers. We thought of offering dermatology screenings, blood pressure checks, as we've been doing, maybe even audiology screenings, because with the heavy use of equipment and the noise factor that farmers are always exposed to, audiology and hearing loss is a real issue, and that can even contribute to dementia and mental health. So we are exploring these different ideas, providing health insurance information, and that peer-to-peer, building that peer-to-peer support network. We are increasing our partnerships with others who rub shoulders with farmers daily, such as those at Farm Bureau, the farm service agencies, and our CS, which is all part of the USDA support for farmers, as well as ag industry partners. And one of the other things we're doing is offering succession planning courses for farmers, because part of the stress, we know that our farm population, the average age of farmers is around 57, and passing that farm on to the children is sometimes a big question of how to do that, when to do that. Do the children even want to farm? If not, then what? All of those questions for succession farming can be a large stress to a family as well. So those are some of the ways, those are some of the things we're thinking of and ways that we're going with this. And I'm so happy at the end today to answer any questions you all might have. Thank you so much for this opportunity.
Thank you so much for your presentation. Up next, we've got Dr. Henry Young, so take it away.
Good morning, everybody. It's such a pleasure to be here with you all. I am going to share my screen. Are you all looking can you see my screen?
Yes.
Wonderful, wonderful, wonderful. Again, it's a pleasure to be here with you all this morning. I'm going to share some information about a little project that we're working on. It's entitled Fishermen Advancing Health. We're really doing this to address chronic conditions in rural Georgia. I am in the College of Pharmacy, so one of the things I wanted to start off by saying is, how in the world am I, connected to this public health initiative addressing rural health? At my heart, I'm a behavioral and social scientist with expertise in health services research. I really like to focus in on medication use, chronic management of chronic conditions, as well as health communication and health outcomes. I particularly like to focus in on minority health and underserved patient populations. So that's how I got to the rural connection. One of the things that I also really enjoy doing is doing work or trying to do work to address individuals or just communities specific problems and issues. So in order for me to do that, I necessarily have to identify how to get out of this ivory tower that we are in and really try to address individuals' specific concerns in health. And, I really, it's a wonderful kind of tie-in to, the previous presenters because, one of the things that we have a resource here at the University of Georgia is a robust public service and outreach unit. And particularly, I worked with some wonderful colleagues at the Archway Partnership to enable me to get out of this ivory tower and to engage and talk. I heard Lisa earlier talk about, traveling to various different communities and talking with people and leveraging those wonderful relationships that the folks at Archway Partnership have developed over time. And it's such a wonderful resource for us. And just to give you all a scope, Archway Partnership is across, has various different communities across Georgia. And the one that I'm particularly going to focus in on right now is an opportunity that was there in Pulaski County. And in fact, what I did was, I had an opportunity to go through each county and talk with the various different community boards there. It just so happened that some folks in Pulaski County really had a need that I had some expertise to perhaps come together and help them address. Particularly, it was the Taylor Regional Hospital, it's a community hospital in Pulaski County, and they really needed to do a community needs assessment. And this was something that they needed to do to abide by Affordable Care Act provisions. And in fact, there's a neat connection here because previously the dean of the College of Public Health was involved in doing this. So she handed the torch over to me to actually get involved in these activities. But it gave me a wonderful opportunity to get into the community to really try to get a better understanding of some of the issues that were there. And in that process, we had an opportunity to review secondary data, county health rankings, as well as to conduct a community survey, as well as focus groups. So I wanted to share some of the information that we saw, just to give you an idea of what's going on in the community of Pulaski and surrounding counties. And as you can see, there's various different health issues there, especially in comparison to Georgia as a whole. And this just points to the need of health issues in rural communities. We also had an opportunity to get in and specifically look at some of the higher health issues and concerns and conditions that were in the population. And from our survey data, we realized that hypertension, obesity, diabetes, these were some key health conditions that were pretty prevalent amongst our sample. We've also looked at what are some of the risky behaviors: poor eating habits, not following medical advice being up there, lack of exercise. And when we got into doing our focus group, some of the issues and things that we found at our focus group really triangulated with some of the issues here, and particularly with education and self-management. So, we had an opportunity to sit back and triangulate all of the information that we had, and we said, okay, so what were some of the issues? And particularly, we found that men in rural areas, that there were some problems there. Discomfort from medical conditions, having poor health, being treated for these chronic conditions, and there was a lack of preventative efforts. So we sat back and we said, well, how do we address these issues? And in fact, there was a point where we were doing focus groups, and a couple of the gentlemen in those focus groups were sitting around saying, hey, we sit down, we talk to our friends, we don't know what to do. Our wives try to get us to go to the doctor. We don't know, what screening we're supposed to have. What are some of the preventative things we're supposed to have? We just don't know. So we realized at that point that, hey, there's an opportunity here. And after the focus group, I asked them, I said, well, you brought up these issues. Would you like to address them? And the gentleman there said, yes, we would love to address them. So, I took that back and said, what are some of the things what are some of the resources that we can bring to bear to address these issues? And, I participate in the Georgia Clinical and Translational Sciences Alliance. It's a interdisciplinary, institutional collaboration, Emory, Morehouse School of Medicine, Georgia Tech, the University of Georgia, but there's also some healthcare partners as well as partnerships at the state and at the national level. What are some resources that we can bring to bear from this Georgia CTSA to help address this issue or to get an initiative started? So, I want to pull out and highlight a couple of faculty members that were really beneficial to or pivotal to moving this forward. Tiffany Washington, she's in the School of Social Work, as well as Brian Rivers, who's over at the Morehouse School of Medicine. We try to put our heads together and try to come up with some potential solutions. We came up with a list. We took that list back to the community and asked some folks in Pulaski County, hey, what are some of these ideas that you like? And what they liked was for us to form a community and academic partnership to really address men in rural areas who might not have access to services. And the overarching goal is to address health outcomes faced by these individuals and to really think about how can we leverage resources in the community to address some of these issues. So we put our heads together and we thought about, what is some sort of multi-level strategy that we can implement? And the strategy that we decided to implement was really based on a community health worker model. Talk about providing education, linkages to services, et cetera, specifically to address diabetes and cardiovascular disease, as well as cancer. We have wonderful connections throughout the Archway Partnership. We have wonderful connections with local government, with the health system, but also with partnerships at the Georgia Department of Public Health and the different health districts, as well as some cooperative extension agents who are in the area who were willing to help us pull this project together. So what we did was we trained rural health, rural church leaders to form and serve as community health advocates for their communities. We realized that one of the key resources in the rural areas were faith-based organizations, churches. And we just so happened to form a wonderful relationship with a couple of faith-based organizations, overarching organizations in those communities to implement this. And what we did was we trained faith leaders to serve as community health advocates. After the training, folks went out to their different communities, conduct health sessions, keeping track of, who participated, the resources that they were able to connect folks to. After this, and here's where I'm saying, after this, we planned on conducting a robust evaluation of this plan. However, those best laid plans, there was something that just happened in society that really threw a monkey wrench into our actual program that we wanted to actually implement. And as you all guessed it, it was COVID-19, the pandemic. And I particularly like to and often reflect on this picture because, oftentimes we think about, well, how has COVID, impacted our lives and the things that we do. And, it's really pivotal because this gentleman in the Argyle shirt, we lost him to COVID earlier on in the pandemic. And many of these individuals, they've had different connections in the communities that kind of slowed things down. So with that, we kind of put everything on pause. I still continue to keep engaged and talking with these gentlemen. And, it just came down to one day. They said, hey, we need to figure out what we can do. What can we do to move on? We need to continue this momentum and strive to improve the health and well-being, especially at this point in time where COVID is just impacting. We need to get information out. We need to get linkages. We need to figure out what we can do. It just so happened that the USDA had a wonderful opportunity. Talk about leveraging. One of the things that the pandemic has taught us is, hey, we need to leverage technology. Technology such as this. To help us connect with, implement different programs. The USDA has a distance learning and telemedicine program that we were just fortunate enough to apply for and receive. So this program allowed us to make connections with some of those umbrella organizations, the Interdenominational Ministerial Alliance, and also the Georgia Union Missionary Baptist Church Association, GUMBA. To implement a robust telecommunications system, a spoken hub model where we're connecting with rural churches in the communities and, providing them with that infrastructure. They're getting the 65-inch display, touch interactive display panels. They're getting cameras, they're getting computers. We're also equipping them with network capacity. The areas that we're focusing in on, Pulaski, Dooley, Macon, Sumter, Ben Hill, and Houston County, and the components so the grant provides infrastructure. But what we're doing is we're implementing our programming and our interventions, and the components that we're focusing in on medication management in my area, diabetes management, and also opioid misuse prevention. So this award allowed us to further our community academic partnership. We have 22 sites, churches that are initially agreed to participate with us. We had to purchase all of this equipment and also help provide internet services to these various different sites. Right now, we're at the stage where we have delivered and installed this telecommunications equipment to 17 sites. And we're right now currently doing network testing of internet services for those particular sites. What we're doing as a part of this project is providing each site with a year's worth of internet services paid for. And as was mentioned earlier, broadband connection isn't the greatest. So the vendors who we're working with are right now conducting broadband tests with various other different service providers to see what are some creative solutions that we can actually implement. We've included some of that technology as a part of the grant to actually go out and do it. We're also creating a hub here at the University of Georgia to help us remotely connect with these various different sites. As this is infrastructure, this is also providing us the ability to implement many different programs throughout this robust network of services. And one of the programs that we're working with now and implementing, Tiffany Washington, again, our colleague from the School of Social Work, has a Houseguest Program. It's funded by the Alzheimer's Association. And what she's doing is providing virtual respite to caregivers, persons engaged with caring for people with dementia, and conducting these various different activities. And right now she's implementing it and trying to identify facilitators and barriers of implementing such a program in this community. So with that, I think I'm within my time, under 20 minutes. So I want to end there and move on to the question and answering session. So I'll stop my share.
Thank you so much, Dr. Young. So we're going to do questions for all three presentations in the chat. So if you have a question, we're going to go in the order that they're received. I just sent a chat to everyone. So before your question, if it's for Dr. Renzi-Hammond and Dr. Beer, just put a 1 before the question. If it's for Andrea Scarrow, put a 2 before the question. If it's for Dr. Henry Young, just put a 3 before the question. So Dr. Young, we have a question for you about your technology that you use.
Henry, that's actually from me. I'm totally curious how you're setting up telehealth in the churches, or identifying exactly how it might fit in their environment, because we're doing something similar with coax, and I think there's probably lessons learned we could share.
So, and I just reviewed your question. This is going to be a question for Tiffany Washington. I don't know the specifics, but I'm going to connect you with Tiff to answer that specific question.
And never mind, I know, I've been working with Tiffany, so I have an idea. Okay. Got it. Thank you.
Yeah.
Then we also have a question for you, Dr. Henry Young. How is virtual respite going?
Oh, that was.
Oh, that's one you were answering?
Yeah,
Okay.
that was the one I was answering. I think that's the one from you.
And everyone feel free to keep sending your questions in the chat. So we have a question for Dr. Renzi-Hammond and Dr. Jenay Beer. What are short-term and long-term implications of the care center in Georgia?
Ooh, that's a good one. Do you want to tackle short-term and I'll tackle long, or?
Doesn't matter. Go for it.
All right.
Something in mind.
All right, so I'm actually going to start with long, because it's the long view that we've been sort of working back from. So the long view, if we had to project forward to Georgia 2050, what we would love to be able to see is a Georgia that actually has incidence of dementia going down. In the short term, we want diagnosis rates to go up. In the long term, we want them to go down, and we want them to go down because a major part of what we're doing is healthy brain curriculum, right? It's to teach people how to adopt positive lifestyle change, to keep their brains sort of front and center in their own, sort of in their own behavior. So we envision a Georgia where there is actually a lot less Alzheimer's disease than there is today. But in the short term, it's going to look a little paradoxical because we want incidence to go up. Incidence in the short term going up just means that more and more people have access to diagnosis and all of the support that goes with it. So we're going with an inverted U here in our short and long term. We don't envision an increase in incidence in the short term to be problematic. That's actually the goal.
I think to add to that, in terms of short-term goals, we've done a lot of work figuring out exactly how we can address this problem, and setting up all the infrastructure here is a challenge, right? An exciting challenge. So really figuring out our flow of how education will lead into a referral for diagnosis, how that then will lead smoothly into post-diagnosis care. We're developing all the flow models and everything to plan that out. But of course, we have to also be ready and prepared to pivot when things don't quite go to plan. So right now we're figuring out that smooth model, so that way we can, deliver in a timely fashion. We have opened our doors slowly for diagnosis, but I think it will soon be a flood, and we're preparing for that flood.
Great, thank you. So next we have a question for all three. How do you envision resuming your projects as COVID continues to disproportionately impact rural Georgians? We can just start 1, 2, 3 if y'all want.
We never stopped. We just pivoted. So COVID for us especially disproportionately impacted older people. It was not just rural Georgians, but older Georgians, of course, were impacted. There were a lot of older Georgians were at higher risk. So it was, for us, it was a lot of time to spend doing our hard work in planning and modeling. So when we couldn't be out in the communities, we were at our whiteboards and we were at our computers together in our own little bubble, trying to figure out how we could hit the ground running again. So the work didn't stop, even though the pandemic might have stopped us from being there. Although we had many a lovely, awkward Zoom with our interest working groups in our communities going, hi, we're still here.
I would say pivot is the right word. I previously had some experience doing telepharmacy work, telemedicine type activities. So us, receiving that huge, so a part of that telemedicine work involves infrastructure. So that USDA opportunity came right on time for us to, try to pull in and leverage that opportunity to build that telecommunication network with our partners in the community, which will then hopefully allow us to implement some of these programs that we want to implement. So it's pivot, it's creative pivoting, still, not losing contact. In fact, I had a couple of phone calls this morning with I call them colleagues, right? My colleagues in the community.
That's great. And we, pivot was an important word for us as well. In early 2020, before we shut down, we did do that face-to-face pilot at our ag production meetings. In 2021, we did most of those online, and we learned to communicate better online with this audience and this clientele. In fact, we had about 3,000 farmers and agricultural producers accomplish one of their critical trainings using pesticides wisely, a critical training online, and we were able to feature the rural stress resources for mental health in those trainings. So we feel like we never stopped. We did have to innovate and create and communicate a little differently. But we're very excited about getting back to those face-to-face production meetings and expanding that work in new counties in early 2022. And during this time, we've been using the time to better equip ourselves and have those conversations with partners that have been so important.
Thank you. I see an email has been put in the chat. I think this is addressing the next question of how does the consumer caregiver of an older adult connect with the care center?
That's it. Care center at uga.edu.
All right. So another question for y'all. I'm an aspiring health administrator. How can MHA competencies provide assistance or incorporate help for the aging community?
My goodness. The answer is yes, like all
Yes
the
to everything.
competencies help. Yeah, we're actually in the process of working with the MHA program here in our very own college, working on strategic planning, laying out all the groundwork for registering as a clinic, and building up our infrastructure to provide that diagnosis support, also post-diagnosis support.
Yeah, when I think of MHAs and I think of the MHA student who is working with us, I think of a person with incredible vision.
Mm-hmm.
When you think of what a patient has to do to navigate diagnosis, and then you think of what a health system has to do to get all the little bits and pieces in place so that a patient has a successful journey through all of that massive amount of infrastructure, it's this massive, massive monumental task. So the MHA student working with us has really been keeping us focused in thinking about what our strategic vision is, and always and continuously rechecking against that vision and asking us, are you going where you want to be going? Are you doing the things that you think you need to be doing? Have you thought of this? Have you thought of that? So it's almost a challenging question for Jenay and I to answer, because we have become, gosh, almost instantly so completely dependent on our MHA student that he's probably really sick of hearing our emails, of hearing the ding that represents another Jenay and Lisa question. So the competencies that you are developing, you are one of MHA students, to me, I think, are the people who really see this from both sides, right? So you're looking at this from the journey of what a patient would do through a health system, and you're looking at the journey of the health system and making those patient connections. That sort of 30,000-foot view that you have is so deeply valuable. And if you want a little time in the care center at uga.edu, we will put you to work.
And also that system might be a little bit different for each community, and there are varying healthcare resources, right? So being able to accommodate and adapt to various rural communities will be really, really, really critical.
Thank you. So for all presenters, the question is, we've heard a lot today about training community members to help each other, but do you think that could be adding a burden of responsibility of individuals where systems are failing them? And how do we navigate that balance? So whoever wants to take that.
Oftentimes the folks who we're working with, they're already serving in this capacity. They're already serving in a more advisory capacity. The church leaders that we are engaged with, they're leaders in the community. They're deacons, or we've even engaged some of the stewardess. They're also pastors, so they're already in this leadership capacity. One of the things that we're finding challenges with is those linkages to other services or linkages to care. Oftentimes we'll have to go in and try to engage some of those different clinics to try to make a good connection for them. But we're trying to align with the strengths and the resources and the capacities that are already there, instead of adding on as an additional burden. We're equipping and empowering those individuals who are already within that space.
I would agree with Dr. Young. It's so important to take that multi-sector approach where it's not just on one agency or another. And we definitely had our ag agents say, whoa, wait a minute, we're not going to be licensed social workers here. We can't take this on. We're not prepared. And we had to be quick to say, no, we're not asking you to do that. There's just this piece of connecting with resources. And so I think that really delineating those responsibilities and helping those partnerships to grow is the way we avoid that overburdening of one community champion or another, because sometimes if you're the only one carrying the torch for that issue, it can feel burdensome for sure. So that multi-sector approach, I think, is what I would point back to as critical.
All right, we have another question for all presenters. With a large number of counties in Georgia, how important are the county health departments to improve rural health?
We can kick this one off. In our experience, vary. Whenever we attend, any sort of working group meeting, the ones that we've attended so far have generally had representation from their county, from the officer in their county health department, and it's often a person saying, yeah, this is a big problem in our community, but it's not one that we have tackled yet. And we've been hearing, I think, a lot of optimism in the notion that even these big problems that feel like they're not within the scope of, of day-to-day work, are quick to become adopted into the scope of day-to-day work. So we've had wonderful conversations with local health department folks on, how often they're using their telehealth systems that exist in all of those health departments, and how much they feel ownership over these problems and how much they don't. And it's that notion of ownership, I think, is really interesting. And I think it sort of relates back to the question that was just answered about, who's carrying the torch for that problem. So in our experience, it's been a lot of excitement, to the point that, one of our closest collaborators are our state level public health counterparts, who immediately dug right in and said, this is a big problem and we need to tackle this.
I would agree. We rely on our health departments and their partnerships very closely. We also have the farm worker health clinics through the Department of Health that have helped us address issues on the farm. So we're very thankful for those partnerships as well.
I would agree. It takes a village. Many of the challenges that are faced in rural communities, and just in communities in general, are multifaceted, and we need again a multi-sectorial approach to addressing these issues. So I would say a very big part of it.
Thank you. It looks like there's a thank you in there for presentation one, if you want to read that. And then if there's any other questions, we've got about 10 minutes. Still got some time if people want to ask questions, but I did send the link to join. The large meeting again is there. It should still be up on your screen if you just click join from there, but if not, that's how you reconnect from that link right there. But we can stay on for a few more minutes. If people have questions, feel free to throw them out. We have another question for all. How challenging was it to develop your metrics to measure the success of your programs?
I'll just say that it is a challenge. We are still in that process, having just piloted part of the outreach. We're still grappling with what questions do we ask? We want to survey the clientele to know how best they want and how best to reach them, and how do they want to even receive the information and the support. So it is a challenge, but I'm very thankful for Dr. Chayette, Dr. Proctor, and others who are helping us hone in on that and really get a good measurement instrument.
Developing the metrics, oftentimes we kind of leverage already, previously validated and developed tools. I would say the implementation of trying to assess those metrics Those are challenging. What format, either interviews or surveys, and who's going to do the surveys, and how are you going to get over it's research. So how do we incorporate IRB and human subjects training, et cetera. So for us, it's more of the implementation side.
Yeah, so one thing we have been learning along the way as we think about impact evaluations is that it might be a little bit different for each community. And through our collaboration with Archway and Extension, we've come to find that our impact evaluation might look different for each county depending on the stakeholder goals. So stakeholders can be quite diverse from county to county. So being sensitive to that and making sure we're moving the needle in all the right ways that's meaningful for that community or for that particular community.
Yeah, we've been asked previously, what does success look like in a terminal illness? Which is one of the statements that makes you sort of stop and be silent for a minute and go, lots of things, right? So it's a tricky situation when you have that many stakeholders. When we started doing stakeholder mapping, it looked like a massive bowl of spaghetti on our boards, of who all had, metaphorical skin in this game, and who all could benefit and what that benefit actually looks like. And for us, I think at the end of the day, we've had to be profoundly flexible in our metrics because we didn't know what success looked like to a lot of our stakeholders until you ask them, what does success look like for you? And then sort of develop metrics around those opinions. So it's, there's easy financial metrics that turn out to not be so easy, that you feel like might be important for everybody. And then when you start digging into the weeds here, what is success? I mean, what is success to a care partner? For those of you who have been impacted by dementia yourselves, what is success to you? And that is a challenging thing to quantify for sure.
And a moving target.
Yeah.
Well, thank you, everyone. And feel free to head back into the main meeting. We do have a little bit of a time built in for a break. So in about 8 minutes, the meeting will resume live. And we appreciate all of you being here and all of the presenters for wonderful, informative presentations. Thank you all.